How's it going, guys? We have a pass level question for renal slash physio slash path for step one. Okay, nearly identical question shows up in one of the nbme exams. Not going to be a lengthy clip. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram at mehlman_medical. mehlman_medical. Links down below. Find me on Telegram. The links to the Telegram group and channel down below. Now start the clip. So 9-year-old girl, progressive fatigue and increased urination for the past week. Pulse 110. Physical exam shows dry mucous membranes and poor skin turgor. Fasting serum glucose 400 milligrams per deciliter. Question wants to know the most likely explanation for the increased urinary output in this patient. So obviously this is diabetes mellitus type 1, okay, in a kid, likely DKA in this case. So you need to know fasting glucose on 2 occasions, 126 or greater is diabetes mellitus, 100 to 125 is impaired fasting glucose, 72 to 99 is normal. Any one random glucose, 200 or greater is diabetes mellitus, and an HbA1c 6.5% or greater is DM. So what's the mechanism for the increased urination here? Let's just whip through the answer choices. Choice A, baroreceptor mediated ADH release. Wrong fucking answer. Okay, so vasopressin. Albeit this is exceedingly high yield on family medicine for 2CK, where this shows up as the answer for why we get hyponatremia in heart failure. Okay, so you need to know that in systolic dysfunction, where we have decreased ejection fraction, the carotid sinus baroreceptors will experience decreased stretch. So the interpretation from those baroreceptors will be as though our blood volume is low. Okay, so in addition to the whole decreased firing of cranial nerve 9, decreased firing of cranial nerve 10, increased heart rate, the autoregulation mechanism, in addition to that, we will also get increased ADH release, okay? Sounds very step 1-ish. But as I just said, it's on the family medicine form for 2CK for why we get hyponatremia and heart failure. In this case, wrong fucking answer. Choice B, disruption of loop of Henle ion gradient. Wrong answer. Refers to nothing, okay? It's just a distractor. When students don't know an answer, they choose obscure sounding shit. You could be aware physiologically that the urine is most concentrated at the trough / nadir of the loop of Henle, and it's most dilute at the top of the thick ascending limb, okay? So the macula densa bridges the early DCT to the afferent arterioles, and USMLE wants you to know that that's always hypotonic no matter what. Okay, it's a long discussion, things we can talk about, but you should know the top of the thick ascending limb is where the macula densa is going to bridge the early DCT to the afferent arteriole. Macula densa, according to USMLE, is going to be hypotonic no matter what. In this case, wrong fucking answer. Choice C, increased glomerular filtration is the correct answer. So you need to know that hyperfiltration is the first change we get in the kidney with diabetes. Okay, so you can't visualize it, but we're getting increased glucose that's being filtered across the glomerulus, and it's going to pull water with it. And that's why we get the polyuria. It's not dramatic, but USMLE assesses it. So I said you can't see this change in the kidney, but it's hyperfiltration is the first change that occurs. Well, you need to know that the first visual change in the kidney, or the second thing that would occur in theory, is thickening of the glomerular basement membrane due to non-enzymatic glycosylation. Okay, and that ultimately will lead to failure of the charge and size barrier, cause diabetic glomerulosclerosis with your nephrotic syndrome. But increased GFR, okay, this is what they want you to know, hyperfiltration initially. And then over time, as the kidney starts to fail, GFR will decrease. Okay, definition of renal failure being reduced GFR, but initially GFR is high. Okay, and that's what causes your polyuria. Let's just whip through real quick. Ketonuria, wrong fucking answer. It's like, yes, you'll get ketones in the setting of DKA, but that doesn't explain the increased urination. And then metabolic acidosis, sure. I mean, DKA is the D in mud piles for high anion gap metabolic acidoses, but that alone has no relation to why we actually get increased urination here. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel. And I appreciate your time. That's it.